population. The driving force behind GERD isn't acid hypersecretion by the stomach, but abnormal lower esophageal sphincter function, which is usually responsible for protecting the esophagus from the normal stomach acid. A little bit of reflux is normal, as the lower esophageal sphincter, or LES, normally relaxes throughout the day to vent gastric pressure. You hear this all day long as burping, but there may be silent episodes of this as well. However, when the LES opens too frequently and for too long, reflux of acid from the stomach into the esophagus may occur. When acid hits the esophagus, which does not have protection strategies for acid, inflammation of the esophagus occurs. Gastric distension, such as with delayed gastric emptying, or increased gastric pressure, such as with obesity, can both lead to increased LES opening and reflux. Joseph Schmo from our clinical case is obese. That's probably where some increased pressure on his stomach is coming from. In addition to increased LES opening, low LES tone can contribute to GERD as well. A long list of things can cause low LES pressure, including chocolate, peppermint, caffeine, alcohol, smoking, anticholinergics, nitrates, calcium channel blockers, tricyclic antidepressants, opioids, diazepam, and theophylline. I'll bet if we question Joe from our clinical case, he'll have some of these too. Seriously though, peppermint? Chocolate? Caffeine? That's all the good stuff in life. Well, maybe not all of it. Pregnancy and estrogen therapy may also increase GERD as a result of estrogen-mediated LES relaxation. Not surprisingly, anatomic disruption of the LES mechanism can lead to increased reflux as well, as is the case with hiatal hernias. Obesity is a twofer here, as obesity both increases LES opening and increases risk for hiatal hernias. Wait, LES mechanism? What's that mean? Turns out there are two parts of the lower esophageal sphincter. First, there's the sphincter muscles, circular muscles that wrap around the esophagus, but there's also the crural muscles, the muscles that control the diaphragm. The esophagus passes through the diaphragm at this point, and the crural muscles help create and maintain the lower esophageal sphincter. Whoa, look out there! That coffee is so hot! The symptoms of GERD are relatively well characterized and are important for guiding workup. The pain associated with GERD is typically described as retrosternal burning discomfort, for example, heartburn, as opposed to the lower epigastric pain of PUD. Always keep in mind, however, that symptoms of these two diseases can overlap and presentations can be variable. Looking back at our clinical case, we could always question Joe further to see whether the pain is really epigastric, or if it's a bit higher, more like retrosternal. Maybe just have him point to where it is. Yum, look at this mousie's midnight snack. But maybe won't make him sleep all too well if it's refluxing back up. Heartburn with GERD usually occurs after meals, just like with Joe, is made worse by lying down, like at nighttime, and may be relieved with antacids. Hey, that's a handy dispenser, especially at a GERD-centric kind of place like this. Pain may occur between meals as well, and may occur at night when patient lies down to sleep. In fact, heartburn that wakes a patient up and is relieved with antacids is an important diagnostic clue for GERD. The sensation of reflux is often present as well, which is described as the feeling of acid or food coming back up into the throat or mouth. This is also called an acid brush and often tastes sour like bile. Patients may also use the term regurgitation, though this is different than the regurgitation of food in esophageal diverticular disease. As with pain, reflux is made worse with lying down. Attendings, especially medicine attendings, get giddy as little schoolgirls for the old saying that all that wheezes is not asthma. And while overly cryptic and not very useful and annoying, it's actually quite true. Laryngeal irritation due to chronic reflux can cause chronic cough or hoarseness. Typically, these happen more at nighttime, especially the cough, because when the patient is lying down, it's easier for the acid to get to the larynx. Wheezing can also occur in severe cases. Again, our clinical case patient had this as well. Seems like we're on the right track for his diagnosis. Remember, though, the question was asking what the best step in management is. Luckily, the approach to diagnosing GERD starts out relatively simply. If there is reasonable clinical suspicion of GERD versus other more serious conditions, a trial of acid-suppressing medication should be attempted. This diagnostic treatment is either PPIs, such as omeprazole, or H2 blockers, such as ranitidine, for 8 weeks, and we've brought back our recurrent symbol for both. 2 bee swatters for H2 blockers, and a protective parasol blocking that acid spray. That's an intense game if it sprays you with acid when you miss. Why is it called a diagnostic treatment? If symptoms resolve completely and the patient has no alarm features, more on that in a minute, then that's it. You've got both the diagnosis of GERD and an effective treatment. So, with Joe having already tried PPIs with good results, could this be our answer? Just get him back on acid suppressive medication. All right, so to sum Oh, we're not done, you say? Good catch. We haven't covered the alarm systems yet. What are alarm systems, you ask? Well, alarm systems are certain symptoms that are concerning for other more serious conditions, particularly cancer. So-called alarm systems include dysphagia, odynophagia, unintentional weight loss, GI bleeding, which can be melena, hematemesis, hematochezia, or even just fecal occult blood, or unexplained iron deficiency anemia. Another alarm feature is a family history of GI malignancy. Think back to our clinical case. Does Joe have these? Doesn't seem like it, but maybe we should ask some more questions of him to make sure. Keep waving that red flag. If there are any alarm features complicating the case, the patient should undergo esophago-gastroduodenoscopy, or EGD at the time of presentation. Patients should also undergo EGD if they are at an increased risk for development of Barrett's esophagus, the intestinal metaplasia that precedes most esophageal adenocarcinoma. Risk factors for Barrett's in the setting of GERD include age above 50, smoking, obesity, a history of GERD lasting over 5 years, or a family history of Barrett's or esophageal cancer. Remember that Barrett's esophagus is transformation of the normal distal esophagus stratified squamous epithelium into the columnar epithelium typically found in the small bowel, and is therefore predisposing to developing esophageal cancer. As we said, patients with risk factors for Barrett's should undergo EGD at presentation. Remember our clinical case? Even though Joe doesn't have any alarm symptoms, he does have a 7-year history of this. So really, what Joe needs is an EGD. I think we have our answer, but there's still more to this discussion. Finally, 50 to 95% of patients with GERD respond almost completely to a trial of PPI or H2 blocker therapy. However, in those in whom PPI therapy doesn't work, EGD is indicated. Look out, kid, you're going to get stuck on that slippery slide. On EGD, GERD-associated features that may be seen include strictures, esophagitis, Barrett's esophagus, high-grade dysplasia, and even esophageal adenocarcinoma. Peptic strictures are concentric narrowings, usually smooth, and occur from recurrent erosive esophagitis, as the body tries to heal the inflammation. It deposits collagen, which over time contracts, narrowing the lumen. Patients may complain about progressive dysphagia to solid foods. These can be treated with endoscopic dilation. Really though, what kind of place has kid slides where it looks like they're getting eaten? EGD is a mainstay diagnostic tool when evaluating suspected GERD, especially long-standing GERD. The chronic inflammation caused by GERD can lead to erosive esophagitis, which has a spectrum of severity. Potential findings can be mild, showing erythema or small breaks, to severe, with deep ulcerations, scarring, stenosis, or Barrett's metaplasia. In all cases, suspicious areas should be biopsied to rule out dysplasia. The most feared complication of chronic GERD is the development of Barrett's esophagus, which involves intestinal metaplasia. As we said earlier, replacement of the normal esophageal mucosa with intestinal mucosa. Barrett's esophagus without dysplasia must be monitored more frequently, with EGD and biopsy occurring every 3 years. This is because it predisposes patients to the development of dysplasia. If patients develop high-grade dysplasia, however, esophagectomy should be considered as the risk if underlying esophageal cancer is high. Esophageal cancer is covered in our vaudeville stage sketch. For more information, you can head there next. As you remember, we've covered GERD-related erosive esophagitis. However, there are a few other types of esophagitis that may be seen on EGD that we need to discuss. These should be ruled out when considering GERD as a diagnosis and cause of esophagitis, because each of these next few conditions can mimic GERD. One such condition is pill esophagitis, where the esophagus becomes irritated by medications. This can be due to either direct mucosal injury, as is the case with tetracyclines, potassium chloride, or bisphosphonates, or due to impaired mucosal protection, as with NSAIDs. Dysphagia or odynophagia are clues that heartburn may be due to pill esophagitis instead of GERD, especially if the patient is using the medications we listed. Another clue leading to pill esophagitis is location, as it occurs most commonly in the mid-esophagus, due to compression of the esophagus by the aorta or left atrial enlargement in some patients. Pills may be stuck at the compressed region. Compare this with GERD esophagitis, which occurs in the distal esophagus. Another GERD-esque disease is eosinophilic esophagitis, which can occur in both adults and children and is highly associated with atopy. Patients most commonly have dysphagia or even food impaction due to esophageal rings or strictures, symbolized by the pink rings around his capsule. A giveaway for eosinophilic esophagitis. It's very wittingly called eosinophilic esophagitis because on biopsy, there's an increased number of eosinophils. Like you couldn't have guessed that. Infectious esophagitis is also possible. In these patients, several viruses and even fungi may cause esophagitis associated with adenophagia and dysphagia, which may be confused with GERD symptoms. In particular, patients who are immunocompromised, such as patients with HIV/AIDS, are at a higher risk of infectious esophagitis. The most common infectious esophagitis in AIDS patients is Candida, which appears as white mucosal plaque lesions. CMV and HSV are also more common. CMV typically has deep, linear, longitudinal ulcers, and the ulcers of HSV are typically well circumscribed and volcano-like. Anywho, let's get back to the main event. Patients who are refractory to medical therapy for GERD, which is maximum dose PPI taken twice daily, should be evaluated for possible surgical treatment. Other indications for surgical treatment are patients with successful treatment with medications but who do not wish to continue medical therapy. For example, don't want to have to take pills daily or twice daily. Patients with complications of GERD like Barrett's metaplasia or strictures, and patients with extraesophageal manifestations like wheezing, chronic cough, aspiration, or laryngitis. Some workup is required preoperatively. Esophageal pH monitoring should be performed. This can help confirm the diagnosis of GERD. The test of choice is pH monitoring with multi-channel impedance measurement. Impedance is a measure of conductivity affected by intraluminal contents within the esophagus. In addition to pH, this test monitors the number of reflux episodes, how high reflux extends, and how long areas of the esophagus are below pH 4. The combination of all these factors gives a de Meester score, or the composite pH score, which gives an idea of total acid exposure of the esophagus. This increases the sensitivity for detecting GERD, as up to 40% of patients with GERD will have what's known as non-acid reflux. Non-acid reflux, as its name implies, involves reflux of material with a pH over 4, non-acid in terms of GERD, that produces the same symptoms as classic GERD. Manometry should also be performed in patients with refractory GERD before any surgical procedures, to ensure normal peristalsis during swallowing and to rule out esophageal motility disorders such as achalasia. In fact, achalasia typically goes misdiagnosed as GERD, sometimes as long as several years. Manometry is a series of pressure sensors placed in the esophagus, which measures the pulsion forces of peristalsis along the length of the esophagus during the swallowing mechanism. Anti-reflux surgery can make things even worse for patients with motility disorders. Anti-reflux surgery is performed with two goals in mind. First, to restore the functional high-pressure zone at the GE junction. Second, to restore anatomic positioning of the GE junction in the case of hiatal hernias. Whoa, that kid's strong! Nice one, kid! And look at her prize! A nice little ostrich. The standard anti-reflux surgical procedure is a fundoplication, easily performed laparoscopically. Fundoplication involves wrapping the fundus of the stomach around the distal esophagus to increase GE junction tone and restore a mechanical barrier to reflux. The most common anti-reflux by far is the Nissen fundoplication. Nissen fundoplication involves a full 360-degree wrapping of the fundus around the distal esophagus. The distal esophagus is freed from the diaphragmatic hiatus and pulled into the abdomen. The fundus of the stomach is then wrapped around the esophagus, meeting on the anterior side. The two portions of fundus are sutured together, and then to the esophagus to prevent slippage. See the stitches in the front of the ostrich's white fundus-like feathers? While the Nissen fundoplication is the most common, there are modifications of the fundoplication which include various partial wraps, such as toupee fundoplication, a 270-degree posterior wrap, and the door fundoplication, a 180-degree anterior wrap. See the only partially wrapped white feathers on the second ostrich? Whoa there, guy! Don't squeeze so hard. The most common complication of fundoplication, of any type, is dysphagia due to over-tightening of the wrap. While dysphagia may resolve on its own, some patients may require endoscopic dilation of the new GE junction, or, if refractory, revision of the fundoplication. Great job! We're all done with GERD and esophagitis. Let's review. GERD is a gastroesophageal reflux disease, which results due to abnormal lower esophageal sphincter or LES function. With decreased LES tone and/or increased LES opening time or frequency, acid refluxes from the stomach to the esophagus, increased gastric pressure as from obesity, or increased gastric distension as from delayed gastric emptying both contribute to LES opening and thus reflux. Chocolate, caffeine, coffee, alcohol, smoking, hiatal hernias, pregnancy, and certain medications also contribute to decreased LES tone and increased LES opening. GERD presents with retrosternal burning pain, which is typically postprandial, worse at night, and relieved by antacids. Other associated symptoms are reflux, chronic cough, hoarseness, and wheezing in severe cases. The diagnosis can be confirmed with the trial of acid suppressive medication for 8 weeks. If successful, the diagnosis is confirmed, and acid suppression therapy can continue as treatment, as long as there are no worrisome symptoms or features of the case that require further investigation. These alarm features make a patient more suspicious for having a GI malignancy and require EGD to rule out cancer. These alarm features or red flags include unintentional weight loss, GI bleeding, unexplained iron deficiency anemia, dysphagia, and duodenophagia. Patients at increased risk of Barrett's esophagus should also undergo EGD. Risk factors for Barrett's esophagus include age above 50, smoking, obesity, GERD symptoms for longer than 5 years, or a family history of Barrett's esophagus or esophageal cancer. Failure of PPI therapy trial is another indication for EGD. EGD may demonstrate strictures, esophagitis, or Barrett's esophagus. Suspicious areas should be biopsied. Barrett's esophagus requires frequent surveillance. High-grade dysplasia or cancer should prompt discussion for esophagectomy. Other types of esophagitis include esophagitis from lodged medications, eosinophilic esophagitis, and infectious esophagitis. Anti-reflux surgery is possible. Preoperatively, esophageal pH monitoring and manometry should be performed to confirm the diagnosis and rule out motility disorders. Anti-reflux surgery is indicated for patients refractory to medical treatment, for patients who do not want to continue medication as therapy, patients with complications like Barrett's esophagus or strictures, and patients with extraesophageal manifestations like chronic cough, aspiration, or wheezing. Fundoplication, or wrapping the fundus of the stomach around the esophagus, is the treatment of choice, with the Nissen a 360 degrees wrap being the most common. The most common complication after fundoplication is that the wrap is too tight, causing dysphagia. And that's where we ended.